Hi, my name is Chee-Wee. So in this series of videos, we'll be exploring the use of SIN model as tool for planning our physical examination. Before we start, I'd like to thank a dear colleague of mine, Kirsty McNulty, for sharing her materials with me, which I've used to develop this series of video lectures. Now the aims of this set of 3 videos are to help us interpret and extract data from our history-taking and subjective examinations to determine the severity, irritability, and nature of the presenting condition. And through our knowledge of the severity, irritability, and nature of a person's clinical problem, we can proceed to plan our physical examination. In this video, we will be focusing on the severity and irritability components of SIN and learn how to extract and interpret information from our subjective examination to determine the severity and irritability of the patient's condition. Before we start, it is important to remind us of the Maitland permeable brick wall model. This model identifies that there are 2 types of knowledge that a health professional can hold: theoretical knowledge within their minds, and also external information obtained through examination of the patient. The flow of both information types flows both ways, and they interact, so that our hypotheses about a patient's condition is constantly tested and corrected by the clinical information we obtain. Therefore, it is important to constantly have a position of curiosity and openness to information that we collect in order to test and correct what we think a patient's problem is. There are many clinical reasoning and planning models to help clinicians come to a preliminary diagnosis and to help them plan out their physical examination to collect the appropriate information that we require. One of these models used often by physios is the SIN model, or the SIN factors. SIN stands for severity, irritability, and nature. To help us appreciate and use this model, we'll be looking at a case study and using it to determine the SIN components for our planning. Here, we have a patient who has come to you complaining of hip pain. During the interview, the patient tells you that the pain is deep, constant, and feels like an ache. You've labeled this pain, pain A. It is about 3 to 8 out of 10 on the numerical rating scale for pain. Some other interesting things on the body chart are the ticks on the body joints. Now, these ticks mean that these joints have been cleared of any problems by the physiotherapist. In the next 3 slides, including this one, a brief presentation of the case will be given to you. A warning here that many abbreviations will be used. This is common in our note-taking, so I'll try to state the abbreviations each time it's being used. So, this is a 52-year-old male who came to you complaining of hip pain. During the subjective examination, as part of the patient presenting condition, PC, you ask the relevant questions for determining the patient's 24-hour pattern of his symptoms. On waking, OW, you noted that pain A is 3 out of 10. On resting, OR, he noted that pain A has become 5 out of 10, and at this point, his hip feels really stiff, and it is now difficult to put on his socks. In the afternoon, PM, pain A progressively increases to 8 out of 10 throughout the day. In the evening, Eve, pain A is about 8 out of 10. At night, when he is sleeping, he gets awakened 2 or 3 times due to pain A. However, he is able to return to sleep after about 5 to 10 minutes. The patient's medication or drug history, DH, is as follows. He uses ibuprofen a non-steroidal anti-inflammatory drug, about 3 times per day. Each dose is about 400 milligrams. He also uses paracetamol, or in our local parlance, the medication is also called Panadol. He uses it 4 times per day. Each time he takes 2 tablets, and each tablet is 200 milligrams. You've asked some questions to find out more about his social history, SH. So, the patient works as a full-time parking warden, and his working week is 5 days per week, and each working day is 8 hours. He is now off sick and unable to work due to pain A. He enjoys brisk walks around his neighborhood in his free time and does this 3 times per week. He is unable to do this now because of pain A. You've also asked some questions to find out what he does that makes the pain worse, also called aggravating factors, and what he does to make the pain better, also called easing factors. The first aggravating factor is sitting. Pain A starts to increase after 5 minutes of sitting. The pain is about 4 to 5 out of 10, and the patient must stand up as the pain increases to 8 out of 10 after about 15 minutes. The easing factor for this is when the patient stands upright or when lying down. After about 5 minutes, the pain reduces to about 5 out of 10. It takes about 30 minutes for the pain to reduce to 3 out of 10. The next aggravating factor is walking. After 5 minutes, the pain increases to 8 out of 10, and the patient must stop walking. The easing factor is when the patient stops walking and takes his body weight onto his right lower limb. Pain A then reduces to about 5 out of 10 after 5 to 10 minutes, and after 20 minutes decreases to 3 out of 10. Now that we have acquainted with the patient's information, let's go back to define what is meant by severity and irritability so that we can find the information from our case to fit these definitions. Severity is describing the impact of a problem on a person's lifestyle. It can include information such as the intensity of the symptom, the description of the symptom, and the incidence of the symptom. The more intense, the more dramatic the description or the high incidence of a symptom, the higher the severity of the patient's condition. We can also gauge the severity by looking at the symptom's effect on the sleep pattern of the patient. This is especially important given the influence sleep has on our quality of life. Another piece of information is the use and amount of medication a patient is using for their symptoms. For example, someone is likely to have a more severe condition if they're taking opioids for the pain compared to someone simply taking paracetamol. The frequency and dosage of the medication can also tell us the severity of the condition. So, based on the explanation of what severity is, what is the severity of our case patient? Is it mild, moderate, or severe? Let's work it out together. What is the impact of the problem on the person's lifestyle? The person is now currently unable to work and also unable to carry out his hobby of brisk walking. What is the description, intensity, and incidence of the symptoms? On a pain scale used, it is between 3 to 8 out of 10, depending on the activity and also on how long he has done it. The pain is concentrated around the groin or hip area, and he hasn't reported it spreading anywhere else. What is the impact of pain on his sleep pattern? The patient is woken up several times a night and falls back to sleep only after 5 to 10 minutes. So his sleep is much disrupted, but not so much that he can't go back to bed. What is the person's use of medication like? The medication is using paracetamol and ibuprofen, which are relatively common analgesics and at a relatively low dosage. However, he has them about 3 to 4 times daily to manage his pain. Based on the following extracted information for determining severity, what is your initial impression of the patient's severity? I would say that this patient's severity would be about moderate to severe, partly based on his pain score, which on average is about 5 out of 10, and it is leaning towards severe or on the high side because of his inability to work and his disrupted sleep. So if you said moderate or high severity, then you're right. You should be able to also justify why you have chosen that level of severity. Now, let's move on to irritability. Irritability is described as the activity type and the vigor or intensity of the activity that triggers the symptoms. You will be looking at two main things in relation to the activity that the patient has identified that causes the symptom to start. The first thing is the activity that provokes the symptom and the time it takes before the symptom appears and starts getting worse. The second thing that you should be looking out for is the activity that relieves the pain, relieves the symptom, and the time it takes before the symptom to subside to a lower level or disappear completely. So where do we extract these two sets of information from? The main information category from your history taking to pay attention to are the aggravating and the easing factors. The aggravating factors tells you the activities that makes the symptom worse and also the duration it takes for the symptom to appear and get worse. The easing factors tell you the activities that makes the symptoms better and also the duration that it takes for the symptom to subside or to get better. So, how do we judge if the symptom is irritable or not? If an activity takes a long time to provoke the symptom, and it takes very little time for the symptom to subside or disappear, then it is considered to be not irritable. If an activity takes a fairly short time to provoke the symptom, and it then takes a very long time for the symptom to subside or disappear, then it is definitely irritable. If it's somewhere between these two extreme situations, you can say that a person's condition is moderately irritable. Okay, so based on the description of what irritability is, let's work out together what the irritability is for our parking warden. Can you identify what the activities that a patient has noted that makes his pain A worse? Yes, the activities of sitting and walking. So let's focus on sitting first. What is the sitting duration before the patient feels his pain worsening? Yes, it's about 5 minutes. And if he doesn't stand up after that, his pain will reach 8 out of 10 after 15 minutes. Now, what makes his pain better after sitting? Yes, standing up or lying down. That is changing his position. It takes about 5 minutes for his pain to subside to 5 out of 10, and it takes about 30 minutes for the pain to reduce to 3 out of 10. So keep that in mind, and let's look now at the next activity that makes his pain worse, walking. When he starts walking, he immediately notices that the pain starts to increase. It takes about 5 minutes of walking for his pain to increase to 8 out of 10, which is a fairly short period of time, and the pain intensity seems to be quite high. How long does he have to stop walking before the pain intensity decreases? About between 5 to 10 minutes for the pain to decrease to 5 out of 10, and about 20 minutes for the pain to decrease to about 3 out of 10. And he has to ensure that no weight is put on his left lower limb for the pain to decrease. So it doesn't take much and too long for the patient's pain to increase, and it takes quite long for the pain to decrease. Based on this, do you think the patient's condition is irritable or not irritable? Yes, the patient's condition is fairly irritable. So we have now determined that the patient's condition is severe and irritable. We'll come back to this again later to use this information of severity and irritability to guide our physical examination planning. To recap, we have looked at briefly the permeable brick wall approach as a way of constantly evaluating and testing our working hypotheses of what the patient's problem is. We've also looked over the SIN model, that is severity, irritability, and nature. Specifically, we've mentioned that this is a useful model for helping extract the relevant information from our history taking and to plan ahead for our physical examination. More specifically, we've also defined what severity and irritability are and what information categories we should be using to help us determine the severity and irritability. In our next video, we'll be diving into the information categories from our history taking that we can use to inform the nature component of the SIN model. In addition to helping us plan our physical examination, this will also help us formulate a preliminary diagnosis of the patient's condition. Great! So I'll see you at our next video.